DUPUYTRE'N'S CONTRACTURE is an musculoskeletal or orthopedic disease condition. Look at this picture shows that DUPUYTRE'N contracture, hand, fascia, tendon, thickened tissue. Look at this. And ultrasound for soft tissue structure assessment. Then MRI. Rarely used, may show extent of facial involvement. Look at this detail going on. Introduction. Dupuytren's contracture is a progressive hand condition that affects the connective tissue under the skin of the palm and fingers. Over time, it leads to the formation of thickened tissue and fibers, cords that can cause one or more fingers, most commonly the ring and little fingers, to bend towards the palm. This condition can significantly affect hand function and daily activities. Definition. Dupuytren's contracture is a fibroproliferative disorder of the palmar fascia, resulting in progressive thickening and shortening of the connective tissue, leading to flexion, contractures of the fingers. Etymology. The term Dupuytren's contracture is named after Baron Guillaume Dupuytren, a French surgeon who described and treated the condition in the early 19th century. The word contracture refers to the permanent tightening or shortening of muscles, tendons, or other tissue, leading to deformity and rigidity of joints. Epidemiology. Dupuytren's contracture affects approximately 3 to 6% of general population, with a high prevalence in male over 50 years old, especially of Northern European descent. The condition is more common in individuals with family history and certain comorbidities such as diabetes and epilepsy. Types. While not formally categorized into distinct clinical types, Dupuytren's contracture can be functionally described as 1. Early stage nodular phase development of painless lumps or nodules in the palm. Second, intermediate stage cord formation, fibrous cords form leading to palpable bands in the palm. 3. Advanced stage contracture phase. Fingers begin to bend permanently towards the palm, reducing hand function. 4. Bilateral versus unilateral can affect one hand unilateral or both hand bilateral. 5. Isolated versus associated forms may be isolated to the hands or associated with other fibrotic conditions like plantar fibromatosis or Peyronie's disease. Causes. The exact cause is unknown but is believed to be multifactorial, involving 1. Genetic predisposition, 2. Abnormal myofibroblast activity, 3. Collagen dysregulation, 4. Microvascular injury, 5. Environmental and lifestyle factors. Risk factors. 1. Age, most common after age 50. 2. Sex, more common in males. 3. Family history, genetic predisposition. 4. Northern European ancestry. 5. Diabetes mellitus. 6. Alcohol consumption. 7. Smoking. 8. Epilepsy. 9. Manual labor or hand trauma. Complications. 1. Progressive hand dysfunction. 2. Inability to perform fine motor task. 3. Psychological distress or social embarrassment. 4. Skin ulceration in rare severe cases. 5. Recurrence after treatment. 6. Surgical complications, example nerve injury, hematoma. Pathophysiology. Pathophysiology of Dupuytren's contracture step-by-step process. 1. Initiation phase, triggering event, microtrauma, genetic predisposition or metabolic changes, example diabetes, may activate fibroblasts in the pulmonary fascia. Inflammatory signals are released, attracting immune cells and promoting fibroblast proliferation. 2. Fibroblast activation and myofibroblast differentiation. Normal fibroblast transform into myofibroblasts, a specialized type of cell with contractional properties similar to smooth muscle cells. These myofibroblast begins producing excess collagen, especially type 3 collagen. 3. Nodular formation. Proliferative base. The accumulation of myofibroblasts and collagens leads to the development of firm, palpable nodules in the pulmonar fascia. These nodules are typically painless and located near the base of the fibers for collagen remodeling and cord formation. Myofibroblasts continue to contract and rearrange collagen fibers into longitudinal fibrous cords. Normal cross uh, linking of collagen is disrupted, resulting in inelastic and thickened fascia. 5. Tissue contraction, contracted phase. As the cords thicken and shorten, they pulled the fingers into flexed position. Most commonly, the ring and little fingers. The skin may become piqued or dimpled due to tethering by the underlying cords. 6. Progression and functional impairment. The contracture become progressive and reversibly without treatment. Over time, patients lost the ability to fully extend the affected fingers, leading to impaired hand function. 7. Chronic pace and recurrence potential. Even after treatment, myofibroblasts may remain active, causing recurrence in many patients. The disease remains localized to the pulmonar fascia and does not involve tendons or nerve directly. Signs and symptoms. 1. Painless lump nodules in the palm. 2. Tightening of skin over the palm. 3. Thickened cords under the skin. 4. Flexion, deformity of one or more fingers, typically ring and little finger. 5. Difficulty with tasks like shaking hands or wearing gloves. 6. Gradual loss of hand function. Diagnosis. 1. Clinical assessment. Palpation of nodules and cords. Degree of fiber contracture measured in degree. Tabletop test. Inability to place the hands flat on a table. 2. Imaging if needed. Ultrasound for soft tissue structure assessment. MRI, rarely used, may show extent of facial involvement. Nursing diagnosis for an impaired physical mobility related to contracture of fingers. 2. Chronic pain related to tissue fibrosis. 3. Disturbed body image related to visible deformity. 4. Risk for injury related to impaired hand function. 5. Activity intolerance related to reduced dexterity. Medical management. 1. Observation in mild cases. 2. Collagens, Clostridium, Histolyticium injection. Example, Exiaflex breaks down cords. 3. Steroid injections for early nodules. 4. Physical therapy, stretching and splinting. 5. Needle epinotomy, minimally invasive needle fasciotomy. 6. Surgical management, limited fasciotomy, removal of affected fascia. Dermofasciectomy, excision of skin and fascia often required skin graft. Open fasciectomy, cutting of cords without removal. Nursing management. 1. Post procedure care, elevation, wound monitoring and pain control. 2. Educating patient on hand exercises. 3. Monitoring for complications, infection, hematoma, nerve damage. 4. Encouraging use of assistive devices. 5. Promoting psychosocial adaptation. Treatment options. 1. Observation and reassurance for mild non-progressive cases. 2. Enzyme injection therapy, collagenase for breaking down cords. 3. Needle fasciotomy, office-based quick recovery. 4. Open or limited fasciotomy, surgical removal of diseased fascia. 5. Radiation therapy, rare early stage cases to slow progression. Psychosocial medicine. 1. Counseling and emotional support addressing body image, functional loss. 2. Support groups connecting with others having similar conditions. 3. Occupational therapy adopting daily activities and promoting independence. 4. Patient education empowering patients with knowledge about the condition. 5. Cognitive behavioral therapy CBT managing anxiety or depression from disability. Prevention. There is no known definitive prevention, but the following may help reduce risk or slow progression. 1. Avoid repetitive hand trauma. 2. Manage diabetes and metabolic conditions. 3. Limited alcohol intake. 4. Avoid smoking. 5. Regular hand exercise to maintain flexibility. In conclusion, DUPUYTRE'Ns contracture is a progressive and potentially disabling condition that primarily affects hand function, early diagnosis, patient education, and appropriate medical or surgical intervention can significantly improve quality of life. While there is no cure or absolute prevention, emerging treatments and holistic care, including psychosocial support, play a crucial role in comprehensive management. Thank you. Have a nice day.